we can start, right? So the very first question is about a patient who is a short statured girl, right? The stature is short. Then there is primary amenorrhea. Then the another hint is webbing of neck, and there is widely placed, very short. She is having primary amenorrhea. You can see this extra. Yeah, yes, the exact answer is Turner. Oh, let me continue. If there is really this problem is continuing, let me know, right? So the stature is short, and when we say short stature, we usually say that it is less than 145 centimeter, right? Then primary amenorrhea means she hadn't menstruating yet. Clear? So no menstruations till now. Webbing of neck has been shown on the image, and there is widely placed dysplastic nipple, right? So widely placed dysplastic nipple. Yes, this is a classical feature of Turner syndrome. So widely placed dysplastic nipples. And yes, if you have this kind of picture, the answer is Turner syndrome. Absolutely right. This is 45XO, right? So this is one of the commonest and easiest question in pathology. And then another question is also from a very common topic, and it has been repeated many number of times, and this is about dystrophic calcification. So in which of the condition dystrophic calcification is seen? And whenever we talk about dystrophic calcification, so whenever we talk about dystrophic calcification, I think most of you must be knowing, we have to, yes, Varsha, absolutely right. So we have to differentiate it from metastatic calcification. Clear? So we have to differentiate, and we differentiate it on two terms. Number one, serum calcium levels, and second is status of tissue. So in case of dystrophic calcification, the serum calcium levels are normal, but the tissue is either dead or degenerated. Clear? Whereas in cases of metastatic calcification, the serum calcium level is high, although the tissue is normal. So these are the two important points based on which we can differentiate dystrophic with metastatic. And yes, in this particular case, atherosclerosis is an example of degenerated state. So here, for dystrophic calcification, the answer will be atherosclerosis. Then another question is about pigment deposition. Here, an elderly person has a perinuclear pigment, and this is classically discussed in relation to cardiac muscle fiber. The clinical picture is given. Now what can be this tissue? So especially in relation to cardiac myocytes. So if you see, you can see the classical cardiac myocytes here, and having central nuclei. So these are the nuclei, and the pigmentation is this one. Okay. So the pigmentation is this one. You can see brown colored pigmentation. Yes, Varsha, absolutely right. So this brown colored pigment is actually known as lipofuscin or lipochrome, and this is known as wear and tear pigment. Clear? So this is wear and tear pigment, and classically described in relation to cardiac myocytes. And we know that in cardiac myocytes, the muscle and the nucleus is central, so we can see the pigment which is nearer to this nucleus. So this brown pigment is all Lipofuscin. Okay, so wear and tear pigment. Absolutely right, Varsha. Then moving forward, which of the inflammatory mediator has a major role in patient who is presenting with swelling on the face and breathlessness after a bee sting? So here we can see it's a classical case of bee sting, and after that the patient is having anaphylaxis. So patient is having anaphylaxis, and here he is having swelling of face and difficulty in breathing. So what can be the answer here? Yes, it is absolutely right. This is histamine, which is a mediator of allergy or anaphylaxis. Clear? So this is classical. Yes, Varsha, this is histamine, right? So this is classically because of histamine. There is swelling over face and there is breathlessness, particularly after bee sting. The next question, a substance was stained with Congo red stained, and then it was visualized under normal light under microscope. So Congo red staining visualized under normal light, and this is the classical picture of that tissue. Now what we can see here, so Congo red, light microscopy, pink appearance, the substance will be right. So Congo red staining and okay, so Congo red staining, and there is pink color appearance under light microscopy. Clear? So when you have this kind of presentation, yes, Varsha, absolutely right, the answer is amyloid. And if we visualized it under polarized light, if we visualize this slide under polarized light, we will see apple green birefringence. Clear? So the tissue is colloid, amyloid, and it depends, the presentation depends on the type of light under which the tissue is visualized. So this is amyloid. Very good. Then moving forward, a 60-year-old patient is a case of chronic renal failure and is undergoing hemodialysis for the same. So 60-year-old patient with CRF undergoing hemodialysis, there is possibility that there might be deposition of some type of amyloid here. Now what can be that amyloid subtype which will be discussed, which will be deposited in a case of hemodialysis? So hemodialysis patient of CRF undergoing the CRF patient undergoing hemodialysis, there is amyloid deposition. Which type it can be? So this is actually A beta 2, right? So in case of hemodialysis, the amyloid deposition will be A beta 2. Okay, so this will be A beta 2, right? So this is A beta 2. Now here double A, this is secondary amyloidosis, and this is especially seen in chronic infections. It can be bronchiectasis. Clear? It can be bronchiectasis, or it can be chronic chronic osteomyelitis. Clear? So this can be chronic osteomyelitis. So AA in secondary amyloidosis. So if we just have a chart of like the dialysis related amyloid, this is beta 2 microglobulin, right? Yes, absolutely right. So this is A beta 2. So A beta 2 microglobulin type of amyloid will be deposited in dialysis patient. So if the patient is on hemodialysis, we will see beta 2 microglobulin. And in cases of chronic inflammations, we will see AA. Okay, so just remember this much. Of course, the primary one is AL, which can be seen in monoclonal gammopathy. Okay, so just remember these few varieties. And ATTR, it can be seen in senile restrictive cardiomyopathy, right? So in relation to hemodialysis, this is beta 2 microglobulin. Then the next question is about a type of necrosis which has been shown with the help of an image, and the clinical condition is brain infarction. So identify the type of necrosis shown in a case of brain infarction. And here we can see the necrosis here. So this is the necrosis. So this is which type of necrosis which is seen in a case of brain infarction. Now when we discuss, very good Shrudis, very good Varsha, absolutely right. Now when we discuss infarction, that is ischemia and infarction, in majority of the tissues it gives coagulative necrosis. Clear? So it will give coagulative necrosis or ischemic necrosis. But in case of brain, it shows liquefactive necrosis. So this is one, you can say, exception where the basic mechanism is infarction, but instead of the coagulative necrosis which is shown in majority of the tissues, the brain is showing liquefactive necrosis. So this has to be remembered. Infarction anywhere in the body, it is coagulative necrosis, but infarction in the brain will show liquefactive necrosis. So please remember that. Now, a 45-year-old male has a history of fever, night sweats, and weight loss, right? So there is a history of fever, night sweats, and weight loss. An X-ray was done, and X-ray showed a lesion in the apical lobe of the lung. So apical lobe of the lung was involved, and the histopathology is shown below. Now what can be the underlying process here? So firstly, we have to think of the condition, what condition it can be, like low grade fever, clear, especially in the evening, then night sweats, and loss of weight. And this is supplemented by a chest X-ray which is showing apical lobe lesion. So apical lobe, you can say, pathology. So if you yes, Varsha, absolutely right. This all goes in favor of clinical diagnosis of pulmonary tuberculosis, right? So this goes in favor of the diagnosis of pulmonary tuberculosis. And now what we see in pulmonary tuberculosis? Obviously we see caseous necrosis. Clear? So in the central we see caseous necrosis, which is like cheese-like material, and this is surrounded by giant cells, right? So there are giant cells, lymphocytes, and modified macrophages. So the answer here is hypersensitivity reaction, which is usually type 4. So there are, at the rim, there is all modified macrophages, lymphocytes, and giant cells, but in the center there will be caseous necrosis. So this is classical picture of tuberculosis. And just to show you with the help of an image, in the center you can see this is caseous necrosis, okay, so cheese like material, and the rim is made up of lymphocytes, epithelioid macrophages, and Langerhans giant cells. So you can see these structures which are forming the rim here. Yes, Varsha Thakur, absolutely right. This is hypersensitivity reaction with modified macrophages, lymphocytes, and Langerhans giant cell. So this is classical picture of tuberculosis showing caseous necrosis. So please remember caseous necrosis for tuberculosis. Then next question is about an example of autosomal recessive condition. Now, which of the condition is inherited as autosomal recessive condition? AR. Any idea which one is autosomal recessive? Now, if you don't know inheritance of a condition, always note down this point that autosomal recessive inheritance is mainly shown by enzyme deficiencies. Clear? Mainly enzyme deficiencies. So if you know any condition in which there is any enzyme deficiency, I think most of you must have read in biochemistry about this. So if you see any condition in which there is enzyme deficiency, you can go with autosomal recessive pattern of inheritance. Now in the given 4 options of question number 9, can you tell me, is there any condition which is presenting with enzyme deficiency? Any condition in which we see there is enzyme deficiency, then I think you can get your answer. So Varsha, Shrudis, if you can just mark out the condition in which there is enzyme deficiency, I think the answer is pretty clear. There won't be any confusion regarding this, right? So just remember the fact that majority of the enzyme deficiency conditions, they present as autosomal recessive. Very good, Varsha. The condition is alkaptonuria, and we know that in alkaptonuria, what is the enzyme deficiency? There is deficiency of homogentisate oxidase. Clear? So this is a easier way of remembering the conditions which can have a autosomal recessive inheritance. Otherwise the list is very long and it is very confusing for the students. Like achondroplasia, it is autosomal dominant. Hereditary spherocytosis, this is autosomal dominant, and von Willebrand is also autosomal dominant. So the answer here will be alkaptonuria. Similarly, it can be phenylketonuria or any other enzyme deficiency conditions. So just take the message. If you see any of the option as enzyme deficiencies, probably it is going to be the answer for autosomal recessive inheritance. Now next question. Now there is a condition that is known as kinky hair disease or Menkes disease. Now then the description of that condition is given, that whenever there is a affected child, he has a peculiar white stubby hair, right? The hairs are white stubby, growth is retarded, there is brain degeneration, and the child dies by the age of 2 years. Okay, so Kinki's disease, the description is given like that about the hair growth, mental and brain degeneration and death. Now there is a lady. So there is a lady, Mrs. X. She is hesitant about having children because her two sisters had sons who died from this disease, and her mother's brother also died from the same condition. Now what can be the inheritance pattern here? Now notice one thing, there is death of, like you can write sisters, sons, right? This is one thing. Then there is death of mother's brother. So what we can see here, now what we can see here, that the condition is affecting only either sons or brother. So it means it is affecting only males. So one point which we can take out from the whole history is that the condition is affecting only males. Now tell me any pattern of inheritance where the males are affected. So this is X-linked recessive. Very good, Varsha. This is X-linked recessive. So for X-linked recessive, just remember two terms. So for X-linked recessive, you need to remember just two terms. Number one, boys, or you can say males affected. Number one, clear? Boys or males affected. And secondly, the condition is transmitted only by affected mother to the son. So there is no father to son transmission. Clear? So there is no father to son transmission because the condition is transmitted by X, and a father gives only Y chromosome to his son. So the condition can be only transmitted by X, but father is giving only Y. So even if the father is a carrier or affected, if the father is affected, he will never transmit the disease to the son because he is just giving Y chromosome to the son, which is not at all a method of transmission of the condition in X-linked recessive. The condition is transmitted only by the X chromosome. So therefore there is no father to son transmission. And secondly, since like if this is the case, suppose, and if the X is muted here, now the Y is not providing any sort of protection. Even you say if the son is heterozygous, only one of the gene is affected, but still the son will be affected because Y provides no protection, as compared to a child where if there is a heterozygous state, the normal gene will give some protection and therefore the girl will be a carrier. But same state, heterozygous state, the boy will be manifesting the disease. So this is the condition, how it differs in females and males. So males, even though they are, you can say heterozygous, but they are not they are not carriers, they are simply manifesting the disease. So boys or males, they are always affected, and since a father will give only Y chromosome to his son, so there is no father to son transmission. So if you find any of these two facts, most likely the pattern of inheritance is XLR, X-linked recessive, right? So mainly affects male and never get male to male transmission, that is father to son transmission. Now, mode of inheritance of a patient who is suffering from color blindness. Now, what is the mode of inheritance in a patient who is suffering from color blindness? So, yes, anyone? Color blindness, it usually affects males. And when I write males, the answer has to be yes, anyone? What will be the answer? If the condition is only seen in males, the answer will be, we just discussed it, the answer will be X-linked recessive. Very good, Shrutis. So the moment you see any condition which is predominantly in males, there is no father to son transmission, straight away mark X-linked recessive. Now another question, certain tumors, they secrete certain chemical or hormone like substance which affect various functions of the body. Now what is this process? So it means there is some tumor in the body and this is secreting some substance, and this substance acts like a hormone. So acts like a hormone. Clear? So now another thing. Now this is related tumor. Now let us discuss normal physiology also. Normal physiology. There is a gland and this gland is secreting this hormone. Say hormone A. And here also it acts like a hormone A. So what will now happen? There will be excess activity of hormone A. So although the body is producing only normal levels of hormone A, but there is a substance which is coming from the tumor, it is also acting like this hormone, and therefore there is increased activity of hormone A. So this condition is known as paraneoplastic syndrome, right? So this activity is known as paraneoplastic syndrome, and this is specially discussed in relation to carcinoma of lung. So if we see, especially in cases of squamous cell variety of carcinoma lung, there is release of parathormone related protein. So, and we know that there is normally secretion of parathormone from the parathyroid, and the activity of the parathyroid, like if we just talk here, so suppose the tumor is a squamous cell carcinoma of lung, and this is producing parathormone related protein. So it is producing parathormone related protein. But on the other hand, normally what happens? There is parathyroid gland, and parathormone gland is producing what? Parathormone. So parathormone related protein is also acting in the similar manner as that of parathormone, and the action is actually increased serum calcium level. So what is happening here? There levels. So this is the concept of hormone related protein, and this leads to hypercalcemia. There can be with the small cell carcinoma where there is syndrome of inappropriate ADH secretion, where there is excessive resorption of water, and that leads to hyponatremia. So these are different. Similarly, there can be increased ACTH, which leads to excess of cortisol, resulting in Cushing syndrome. Okay, good afternoon, good afternoon. Now, which of the following is a component of apoptotic bodies? So which of the following is a component of apoptotic bodies? Now before that, we need to understand what actually are the apoptotic bodies. So what is happening, like whenever there is apoptosis, the cell the nucleus will shrink, it will degrade, the organelles will also degrade, there will be formation of membranous blebs, and finally the cell will break down into smaller fragments. So what is happening here, like if we see, this is the normal cell, clear? So this is the normal cell. During apoptosis it will shrink, the cell will shrink, the nuclear chromatin will condense, so there will be pycnosis, karyolysis, karyolexis, and as a result of this, now the membrane will also starts blebbing. Blebbing means it will something like this. So it will also form cytoplasmic blebs. There is disintegration of the cellular organelles, and finally what will happen, the nucleus and organelles will collapse, but the membrane will continue to bleb, and finally the different apoptotic bodies will separate out. So what actually is there in the apoptotic body? There are nuclear remnants, there are cellular remnants, and these are covered by a membrane. So this is the apoptotic bodies. And here, therefore, what will be the answer if you are discussing component of apoptotic bodies? Obviously it is having cytoplasm, right, which is covered by a membrane, and there are products of nuclear disintegration and cellular disintegration. So this is the component of apoptotic bodies. So cytoplasm, nuclear material degradation product, and cellular disintegration product. So these are the apoptotic bodies here. The next question, which HLA is related to Reiter's syndrome? Which HLA is related to Reiter's syndrome? Now just a few more words about Reiter's syndrome. This is also known as reactive arthritis, and this can be secondary to UTI or at times some GIT infection. So it can be secondary to this. And here the classical presentation is, you can say, conjunctivitis, then obviously there is urethritis, and third there is arthritis. So these are the three important features: conjunctivitis, urethritis, arthritis. And yes, anyone, what can be the HLA for Reiter syndrome? This is HLA B27, same as that of ankylosing spondylitis, right? So this is Reiter syndrome, which is also known as reactive arthritis. Next question, what is the correct sequence of wound healing? Right? Yes, Varsha, absolutely right. This is HLA B27. Kakul, absolutely right. HLA B27. Now, which of the following depicts the correct sequence of wound healing? So you have to tell me what is the correct sequence in which a wound heals. Yes, anyone? Correct sequence of wound healing. See, if there is a wound, what will happen? There will be bleeding from here, right? So there will be bleeding. Now what the body will try to do? So body will try to control or stop bleeding. So body will try to control or stop bleeding, and this is what is known as hemostasis. This is what is known as hemostasis. Clear? This can be, body can achieve this by vasoconstriction. So the initial step has to be hemostasis. After that only wound healing will proper start. So the very first step has to be hemostasis, and therefore the answer is pretty clear. It has to be hemostasis, inflammation, proliferation and remodeling. So the only hint here is choose an option with starts with the word either hemostasis, and if hemostasis is not given, then at least vasoconstriction. So choose only that option which starts with hemostasis or vasoconstriction. So the answer is option D here, hemostasis, then there will be inflammation, then there will be proliferation of the tissue, and finally there will be remodeling, right? So hemostasis, inflammation, proliferation and finally remodeling. So that is the correct sequence. Yes, very good, Varsha. Chalo, next question. A pregnant lady has thalassemia trait. The husband is also thalassemia trait. Now, what is the possibility of the offspring to have thalassemia trait? Right? So, now, what do you mean by the word trait? Trait is actually carrier. And this thalassemia, it has autosomal recessive inheritance. Now, what happens here? Suppose if the mother is like this is mutated gene, and if suppose the father is like this is the mutated gene. So both the mother and the father, so this is mother and say this is father, so both the mother and the father, they are carriers, they are trait, because they are heterozygous. So this is actually heterozygous. Heterozygous. Only one gene is affected. Clear? And autosomal recessive conditions, they manifest only in homozygous state. Only if the child is homozygous, like AA, so both the genes are mutated, then only he will manifest. So a person who is having homozygous will manifest. A person who is heterozygous will be a carrier. So let us see now what can be the outcome of this couple. So this is the mother, this is the father. So what outcome we can have? We can have A here, and then we can write A and A here, okay? Then we can write A here and A here. So what will happen? Only one of the four will have the homozygous state here. Okay? So only one of the four will have the homozygous state here, and therefore the two will have the heterozygous state. Okay? So the two will have the heterozygous state, and that is, you can say, these are both the heterozygous. So here 2 will have the heterozygous, and out of the 4 1 will have the homozygous. Okay, so let's write homozygous here. So homozygous like this. So only 25% will have the disease, right? So this is the disease, and 50% will be the trait, having the trait, or they will be the carriers. So the question is about the trait. So the answer will be 50%. So 1 will be normal, 2 will be carriers, and 1 will be affected. So this is the pattern of inheritance in case of autosomal recessive if both the patients are traits or carriers, right? So this is 50%, right? So this is how we can remember it, like if both, this is the homozygous condition, right? So the patient will have the disease, 50% will be the trait or the carriers, and 1 will be the normal. So this is usually the presentation. So this is 25%, this is 50%, and again this is 25%. Clear? So this is the case. 50% will be trait, 25% will be normal, 25% will be affected. Okay, so this is how beta thalassemia inheritance is discussed if both the patients are, if both the parents are trait. Okay, so 25%, 50%, and 25%. Then next question is about a patient is having jaundice, and when we checked, it was unconjugated bilirubin which was in excess. So what can be the condition here? So here we need to discuss a little bit about bilirubin metabolism. And once the bilirubin is taken to the liver for conjugation, so in liver it is conjugated, and from liver it is taken to the second part of duodenum through the common bile duct. So this is the common bile duct, right? Now if there is excess of unconjugated, because this is unconjugated bilirubin here, so if there is excess of unconjugated bilirubin, what can be the reason? Either there is increased production, as we see in hemolytic anemia. So either there is increased production which is beyond the capacity of the liver to conjugate, or there is some problem with the liver so that it is not able to conjugate even a bilirubin which is produced in normal amount. So these are the two scenarios of unconjugated hyperbilirubinemia, and here it is Gilbert syndrome, right? Otherwise in other conditions we always get conjugated. So this is Gilbert syndrome. Clear? So on unconjugated, just remember two facts: either there is hemolytic anemia, so that there is excess production of bilirubin, or there is any condition of the liver so that the liver is not affected, is not capable of normally produced bilirubin, right? So Krigler-Nazar and Gilbert, these are the two conditions related to unconjugated hyperbilirubinemia. Okay. Moving forward, a young lady presented with malar rash. So there is a rash over the cheek, and on lab test there is positive anti-Smith antibody, and there are small sterile nodules which are present on the heart walls. Okay. Yes, classically the moment you find this word malar rash, or what you say butterfly rash, the moment you have this word, of course you can think of SLE, but there is some more hint: anti-Smith antibody, right? And there are vegetations on the heart walls which are sterile, means nothing related to bacteria, so non-bacterial. So yes, this is a classical presentation for systemic lupus erythematosus. Yes, SLE, classical SLE. Now, a lady is having progressive dysphagia. She is having difficulty in, yes, Varsha, absolutely right, this is SLE. So, a lady is having progressive dysphagia. She is having difficulty in swallowing, and then when she was examined, there was thickening of the oral mucosa, right? So there was thickening of the oral mucosa, and she was having a leather-like skin. Okay, leather-like skin. She is also hypertensive and she has limited exercise capacity because of lung fibrosis. So you can see there is a multi-system problem affecting GIT. Then she is having skin problem, then there is lung problem. So this is a classical presentation of anyone. What can be the answer here? Dysphagia, lung fibrosis, skin thickening. This is classical of scleroderma. Okay, so scleroderma, right? So this is classical of scleroderma. The next question. Yes, Varsha, absolutely right. This is scleroderma. Then moving forward to the next question, and here elderly male has been working in the dye industry, right? So the elderly male has been working in the dye industry for over 30 years and he developed bladder symptoms, especially painless hematuria. So what we can see here, chronic exposure to dye, right? So there is chronic exposure to dye, and now she is having, and the patient is having painless hematuria. So the patient is having very good. So this is a classical picture of transitional cell carcinoma, urinary bladder. So classical picture. Now remember here one thing, why we are saying transitional and why not squamous? Because squamous is especially seen with schistosomiasis. Clear? Schistosomiasis should be answered only if there is any history related to the schistosomiatic infestation. Then moving forward to next question, there is a young male who is having a testicular mass. Now this testicular mass is painless. Alpha fetoprotein is not elevated, but LDH is elevated. So testicular mass which is painless, AFP is normal and LDH is elevated. So this is the description which is being given in the patient, and of course the patient is 31 years old. So these are the 5 points which are given in the case. Young male, testicular mass which is painless, alpha fetoprotein normal, and lactate dehydrogenase is high. Now this is classically suggesting which testicular tumor? Yes, anyone? Which testicular tumor? This point is very important. LDH is high, then young male. So this goes in favor of classical seminoma. Okay, so this type of picture goes in favor of classical seminoma. So if we see here in seminoma, right, if we see in seminoma, the alpha fetoprotein is normal, whereas lactate dehydrogenase is high, and also beta HCG is high. Yes, Shruti is absolutely right. This is classical seminoma. LDH is high, HCG is high, but not alpha fetoprotein. Alpha fetoprotein is normal in seminoma. So please remember this equation. It's very important, seminoma. Now next question, a elderly male has presented with lower backache, and when the X-ray of the lumbosacral region was done, it showed osteoblastic changes. So old male, right, backache, and there was osteoblastic changes. Now what do you mean by this word osteoblastic changes? It means osteoblast means new bone formation. Clear? So there is new bone formation, and new bone formation, especially in an old male, this can be because of metastasis to spine. And this metastasis in a male, yes, this is metastasis to bone, and especially in a male, which tumor leads to this kind of metastasis? In a male, which kind of tumor leads to osteoblastic metastasis? This is carcinoma of, which is exclusive to male. I am again repeating, exclusive to male. So carcinoma of, very good. So this is carcinoma of prostate. Okay, so this is carcinoma of prostate. Now remember one thing, usually majority of the metastasis to bone are osteolytic. So remember one thing, right? So majority of metastasis are osteolytic, means they destroy the bone. So these are osteolytic, means they damage the bone, right? So they damage the bone. But carcinoma prostate are the ones which actually lead to formation of new bone. So that is very unique for carcinoma prostate. Okay, so if we look at the X-ray here, we can see whatever this white area you are able to see here in the pelvis, this is all metastasis, and here this is all new bone formation, looking extremely white. So this is all osteoblastic. Remember, I am again repeating the word osteoblastic. And for osteoblastic, just remember one tumor, carcinoma prostate. So these are the metastases from carcinoma prostate into the bones. Okay, so osteoblastic metastasis. Now next question. A lady is having abdominal mass, right? So a lady is having abdominal mass. She was investigated, and when surgery was done, she was found to have bilateral ovarian masses with smooth surface. So this is very important, smooth surface. Clear? And then when we studied the ovaries, we could see this kind of picture here. Now what we can see in this histological picture, we can see some rounded forms which have some blue color tip, right? So they just look like a ring. Okay, so they just look like a ring, and if I draw it, they are somewhat like this. So you can see a rounded structure, just see here, rounded structure, and on the top of that we can see a blue, something like this. So we can see cells which are like this. Yes, anyone? Now what you can see here, you can see this rounded form, and on the top of that you can see some. So yes, anyone? So we can see classically something like this. So this is what? This is a, you can say, a ring appearance. So smooth surface of the ovaries, and these are actually known as signet rings. So signet rings on biopsy, what can be the tumor here? Signet ring appearance on biopsy of ovary, what can be the tumor here? Now this is one tumor which is actually a metastasis. Now these are actually direct droppings from the stomach. So the cancer cells, they directly drop from the stomach right on the surface of the ovary, and this is a kind of actually metastatic tumor to the ovary, which shows the typical signet ring appearance, and this is the Krukenberg tumor, right? So this is the Krukenberg tumor. And when I say Krukenberg tumor, just remember 2-3 points. Number one, these are actually metastatic tumor. Very good, Varsha. So this is actually metastatic tumor. And when I say metastasis, from, suppose if this is ovary, so from where the tumor is, if this is stomach, the cancer cells, they are dropping like this. So they are reaching up to the ovary. So the primary or the metastasis in the primary site is in stomach, and the cells, they drop down over the surface of the ovary. So this is a classical ovarian tumor. So primary in stomach, secondary is in ovary, and these are actually direct droppings and giving rise to the classical signet ring appearance. So please remember, signet ring appearance in ovary, this is Krukenberg tumor. And here I think I should also discuss one more condition. Okay, this is the signet ring appearance. Here you can see the cell. The nucleus is just pushed to one side, and there is a big vacuole within the cell. So this is the classical signet ring cell. Now signet ring, you can also remember one appearance or one finding in case of bronchiectasis, right? So if we take CT scan of bronchiectasis, we can also see signet ring appearance over there, right? So better write it, signet ring appearance. So just remember these two conditions where you find this word signet ring. Then moving forward to another question, where a patient was having arthritis, that is joint problem, there is enlargement of liver and spleen, there is increased skin pigmentation, and there is high serum ferritin level. So now what is happening here? Joint problem, okay. There is enlargement of liver, spleen, okay. Then skin pigmentation, right? And if you look at the skin here, it is bronze in color. Clear? So it is bronzed colored, and then there is raised serum ferritin. Now what is serum ferritin? Serum ferritin is iron stores. So if the iron stores are more, it means there is increased iron in the body. Clear? Yes, Varsha, absolutely right. So this is a classical picture of hemochromatosis. So here the patient will have one more thing, that is diabetes mellitus. So this condition is also known as bronze diabetes, right? So there is bronze color of the skin and there is diabetes. So this condition is also known as bronze diabetes. Clear? So this is a classical presentation of hemochromatosis. Iron stores are high, there is bronze color pigmentation of the skin, there is diabetes, joint problem, and so this is how you can see this is normal person's skin and this is hemochromatosis, right? So this is hemochromatosis, bronze color. Clear? So this is bronze color. Fine. So this is how the skin appearance look like. And then the last question, a patient has liver disease, there are tremors, there is poor coordination, there is mask-like facies, and there are psychic symptoms. This problem is because of what condition? So here what we can see, there is liver disease. Clear? There are neurological signs. So neurological signs in the form of tremors, that is shaking of fingers. There is poor coordination. Clear? There is psychic symptoms. So this is classical presentation of Wilson disease. Okay, so this is classical presentation of Wilson disease, and this is also known as hepatolenticular degeneration. So the other term for this condition is hepatolenticular degeneration. So now what is the defective gene, and what is the location of the defective gene in the chromosome? Which chromosome? So for Wilson disease, the answer is, first of all, you should remember this is chromosome 13 and the gene is ATP7B. Okay, so this is ATP7B gene on chromosome 13. So this is for Wilson disease, right? So this is the Wilson disease classical presentation, and this is the gene mutation, that is ATP7B on chromosome number 13. And some people, they just count the number of words in Wilson disease and they say that it is 13, so you can remember that it is chromosome 13, but this is ATP7B gene on chromosome number 13, right? So this is ATP7B gene on chromosome number 13. So this is enough for this session, and I am very sure you might have enjoyed the session. Very shortly I'll come up with the microbiology PYQ session. So keep on studying. God bless. See you soon. Bye bye.